Okay, good afternoon and welcome to the Health and Human Services Committee. Some would say the best committee ever. I would not disagree. My name is Senator Ben Hansen. I represent the 16th Legislative District in Washington, Burke, Cumming, and parts of Stanton counties, and I serve as chair of the Health and Human Services Committee. I would like to invite the members of the committee to introduce themselves, starting on my right with Senator Ballard.
Bo Ballard, District 21, Northwest Lincoln and Northern Lancaster County.
Good afternoon. My name is Lynn Walz, and I represent Legislative District 15, which is Dodge County and Valley.
Michaela Kavanaugh, Legislative District 6, West Central Omaha, Douglas County.
Also assisting the committee is our legal counsel, Benson Wallace, and our committee clerk, Christina Campbell. And our committee pages for today are Peyton and Delaney this afternoon. A few notes about our policy and procedures. Please turn off or silence your cell phones. We will be hearing 4 bills, and we'll be taking them in the order listed on the agenda outside the room. On each of the tables near the doors to the hearing room, you will find green testifier sheets. If you're planning to testify today, please fill one out and hand it to Christina or one of the pages when you come up to testify. This will help keep an accurate record of the hearing. If you are not testifying at the microphone but want to go on record as having a position on a bill being heard today, there are white signage sheets at each entrance where you may leave your name and other pertinent information. Also, I would note if you are not testifying but have an online position comment to submit, the legislature's policy is that all comments for the record must be received by the committee by noon the day prior to the hearing. Any handouts submitted by testifiers will also be included as part of the record as exhibits. We would ask if you do have any handouts that you please bring 10 copies and give them to the page. We will be using a light system for testifying. Each testifier will have 5 minutes to testify. When you begin, the light will turn green. When the light turns yellow, that means you have 1 minute left. When the light turns red, it is time to end your testimony, and we'll ask you to wrap up your final thoughts. When you come up to testify, please begin by stating your name clearly into the microphone, and then please spell both your first and last name. The hearing on each bill will begin with the introducer's opening statement. After the opening statement, we will hear from the supporters of the bill, then from those in opposition, followed by those speaking in a neutral capacity. The introducer of the bill will then be given the opportunity to make closing statements if they wish to do so. And on a side note, the reading of testimony that is not your own is not allowed unless previously approved. And we do have a strict no prop policy in this committee. With that, we will begin this afternoon's hearing with LB 772 and welcome up Senator Hughes to open.
Yeah.
And no pressure with your daughter right behind you staring at you.
None. I feel like there's a cedars reference. I feel like I should bring a cedar branch, but that would be a prompt. So, okay. Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. My name is Jana Hughes, Janahughes, representing District 24. I am here to introduce LB 772, a bill to aid in the construction of a facility for pregnant and parenting homeless youth in Nebraska. I would like to thank the co-sponsors of LB 772, Senator Dungan of Lincoln and Senator Brewer of Gordon. So why are we here today to hear about LB 772? It's exactly as Governor Pillen stated during his inaugural address, that we should never, ever give up on a kid. Colleagues, we must work hard to support our young people in difficult circumstances. This is especially important when poverty, homelessness, a lack of education, and healthcare threatens to become a multi-generational issue. Last year, there were 85 homeless teenagers in Lincoln area alone who were either pregnant or parenting a young child. This is not an issue limited to Lincoln, but is indicative of a larger problem statewide. LB 772 will create a grant for constructing a facility to care for homeless, pregnant, or parenting teens from across Nebraska. This facility is not simply providing a roof over the heads of the homeless pregnant teenagers, although that's a very important function. This facility is intended to provide the training and the skills to manage being both a successful parent to their child and becoming a productive citizen. This facility is not only preventative care and support for the young mother and her child, but also a preventative measure for our state in terms of averting costs down the road. I also would like to take the opportunity to point out a few specifics of the bill LB 772. This bill directs the facility to be located in a city of a primary class. Why would a senator from District 24 introduce a bill that limits the placement of such a city to a city of the primary class? because related facilities that work with homeless youth who are in the foster care system or who are diverted from the criminal system presently exist in cities of the primary class. We need to leverage our tax dollars wisely and utilize such existing facilities, programs, and organizations that already interact with these at-risk kids. I will reiterate that the youth who will benefit from this program will be from our entire state, from your districts and mine. Homelessness is not a problem limited to our cities. Rural Nebraska also has homeless teenagers, many of whom are also pregnant or parenting an infant. Actually, the first youth who is currently piloting this program is from the very center of our state, from Senator Brewer's district. LB 772 also requires that the applicant for the grant created by this legislation must be a licensed residential child caring agency. In short, we want the applicant for this grant to be licensed to have youth in their care. The bill also further specifies that the applicant must be providing street outreach services to homeless youth. Again, we want the provider of these services to be experts in the field. Knowing how to work with the youth who have experienced this specific kind of trauma in homelessness and to already have the trust of the kids currently on the streets is important. There will be others behind me who will talk more about the specifics of the program that will be built out, and I am excited for you to hear about how we as the legislature can partner with them to help serve these kids.
All right,
Any
thank you for that.
Yeah, thank you.
Are there any questions from the committee? Yes, Senator Kavanaugh.
Thank you. Thank you, Senator Hughes. So the intention is to build a facility.
The intention is to, the intention is to add on to a facility that they already have to do it, yeah, but it would be for capital, yes, to build.
In Omaha or Lincoln? Is there a specific facility?
There is a specific facility, Cedars program.
Okay. In Lincoln?
Yes.
Okay. I asked because the Department of Health and Human Services just sold a large property that previously housed parenting youth
Is that right?
in Geneva for $250,000, I think was the auction on governmentauctions.com or something like that. Senator Brandt can certainly fill us in. He has a long memo about it.
Happy to do that.
And I'm sure Cedar can also fill us in because I think that they were interested in the property prior to that. But that's just some historical context for you.
Thank you. I appreciate that.
So this is a program, I mean, obviously it's written and if others qualify, they can apply for it. But the intention behind it is that Cedars would like to create this program in
That is
the
correct,
Lincoln
in
area.
addition to some that they already have. And the intention is the program, they're not there like long-term. It's around like 120 days to kind of learn, just learn how to do laundry, learn how to, live. And then they can help them get into services where they get their own apartment and things like that. But the fact that they could function on their own and teach them those skills.
Okay,
So,
and is Cedars testifying?
Yeah, they
'Cause
are.
I have some
They will
other
be.
questions.
Yes.
Thank you.
Yep, they'll be behind me.
All right. Any other questions from the committee? All right, seeing none.
All right,
We'll see you
thank
to
you.
close.
I will be here.
All right, and so with that, we will take our first testifier in support of LB 772. Welcome.
Thank you. Chairperson Hansen and members of the Health and Human Service Committee, my name is Christina Lloyd, Christina, and I serve as the director of the Cedars Bridges Transitional Living Program and the Youth Opportunity Center, Lincoln's drop-in center for youth in crisis and those experiencing homelessness. Over our 75-year history, Cedars has evolved along with emerging best practices to provide excellent, nurturing, nationally accredited care for Nebraska's most vulnerable kids. Its legacy of responding to the changing needs of kids in our community continues to this day. Cedar's founding program, Emergency Shelter for Kids, remains at the core of our now broad array of services, and it has operated at near capacity since the disruption of the pandemic. Accompanying the critical need for Cedar's current services has been a significant number of referrals for youth experiencing homelessness who are pregnant or parenting their own young children. Every month, Cedars receives dozens of referrals from various sources. Each of these young people need a safe place to spend the night, and each one deserves the stability of a home. Based on various studies, it is estimated that there are more than 350 youth experiencing homelessness or in an unstable living situation on any given day in the Lincoln area. Of those, 85 are pregnant or parenting their own young children. We are comfortable with the number of youth in this often desperate situation to be proportionally larger in the Omaha area. To serve this vulnerable population, Cedars is planning to build the Carriage House, a 6,800 square foot structure on our 5-acre campus at 6601 Pioneers Boulevard in Lincoln. This structure will include 4 one-bedroom apartments and 2 two-bedroom apartments, as well as a common space for youth and staff space for regular supervision and support. Cedars will provide 90 to 120-day intense program focused on building independent living skills and education support. We plan to serve up to 24 youth per year in this program. Mental health and therapeutic services will also be in place to provide specialized prenatal and postpartum support for the young moms. Once safety and stability have been achieved, the goal for each youth in this vital program is to prepare them for successful community living by giving them the skills they need to change the trajectory of their family's life in a positive direction. On a personal note, the Carriage House would have been very beneficial when I found myself pregnant at 16. I'm much older now. I didn't think I'd be emotional about it, but
I said, nobody ever cries in this committee.
I just got told if you can get through it without crying, you're doing good.
Yeah. When I say that, I mean 80% of people end up crying. So you're fine, you're doing good.
My parents made it very clear they did not support the pregnancy, which left me very limited options. I knew I wanted to finish high school. I wanted to go to college. I had goals, and I didn't know how I would achieve those goals with an infant. So after my daughter spent 2 weeks in respite care, I did place her for adoption. Not because I didn't want to try and bear it, excuse me. But because of unsupportive parents and a lack of resources in our community, I felt I had no other choice but to place her for adoption. Had the Carriage House existed, I would have had the chance to finish school, go to college, and learn to parent my daughter in a supportive and safe environment. So with that being said, I am respectfully requesting your approval of this one-time grant fund for the kids in this very difficult situation. This $2 million will be a historic help towards the $3 million cost of making it a reality. Thank you for your consideration, and I'm happy to answer any questions.
All right, you made it. Okay, are there any questions from the committee? Yes, Senator Kavanaugh.
Thank you so much. Thank you for sharing your personal story as well. And yeah, I cry like every day in this committee. It's kind of a rite of passage. I wanted to know a little bit more about how this would work. How would the youth that would come through this facility, how are they referred, or how do they come to you?
Yes. So we currently have multiple referral sources, which include the Department of Health and Human Services, juvenile and probation, and then, but for this particular program, we anticipate a lot of young people coming from the streets, so coordinate entry, potentially just reaching out to us themselves, like they've filled out a contact form on our website, which is then put us in contact with them.
And how many youth would you be able to take in? I'm sorry.
So currently, it would be 6 youth at a time, and we anticipate with that 90 to 120 day programming to move them into their own community-based apartment, or maybe Lincoln Housing Authority with a voucher, and then be able to serve at least 24 youth per year.
Okay. And I don't know how familiar you are with our youth rehabilitation treatment facilities, but some of them, we do have a girls' campus in Hastings now. And so would this facility have the potential of having a youth that might be sent there referred to you instead?
I am not familiar with the
That's okay.
facility, so sorry, I'm unable to answer that.
That's all right. Thank you.
Any other questions from the committee? All right, seeing none. Thank you very much.
Thank you.
All right, we'll take our next testifier in support. start whenever you're ready.
Okay. I'm Ashley Shum, and that's spelled Ashley, SHUM as in mother. I am currently the Assistant Program Director of the Cedars Youth Emergency Shelter. We run 24/7. And I just wanted to start by saying, in a perfect world, young teen parents would have community care, supportive funding, and available medical professionals and mentors. I was 18 years old when I found out I was pregnant with my daughter, Lexi. The thought of becoming a teen mom was difficult, but my life was already in shambles as 9/11 had just occurred and I was soon shipping off to boot camp in the Navy. I had a decision to make: keep the baby and have no clue about how to parent, or not keep the baby and walk into a war zone. I chose to keep my daughter and live through one of the most critical times of my life, but not regretting one moment of it. I had little to no family support during and after my pregnancy. My mom wanted me to have an abortion because it would ruin my life. She eventually came around after my daughter's birth, but I missed out on that connection I so badly needed with my own mother. My boyfriend's family made me feel guilty if I chose not to keep the baby. They made it very clear that they would financially help their son raise the child with or without me. I had my mother who felt I should end the pregnancy and my boyfriend's family who wanted me to give them the baby and raise it themselves. I knew at this point his family and mine would never respect my opinions, thoughts, or any sort of parenting that I did in the future. I felt devastated and alone. His parents had the financial stability that my parents could not provide for us. Unfortunately, there was always the, if we help you out, you need to help us out with this mentality. Others may have seen this as a support system, but this was not a support system. This was toxic, and it was not about safety and stability. Cedars Carriage House will provide knowledge and access to safety, stability, and community support for these young youth. During and after my pregnancy, I had no idea on how to gain access to resources, not only for myself, but for my child. I needed support enrolling in college myself, as my parents did not have any money to pay for my college. And joining the military was the only option for me to go into college. I needed childcare funding so I wouldn't be forced into having my child's paternal grandmother babysit my daughter. That would potentially cause my daughter to miss out on any social interaction that she needed to have with other children, as this is a part of child development. I needed support with parenting classes, health insurance, and food. I deserved access and support as a young teen mom during this and after my pregnancy. Carriage House will provide stability and independent living for these kids to gain access and knowledge to these resources. Postpartum depression is real. Having a new unplanned baby and trying to manage my stress was extremely difficult. I couldn't breastfeed, which made me feel even more inadequate as a mother. I did not have a support system. So I felt sad, scared, and overwhelmed. At that time, I never considered that I had postpartum depression symptoms, let alone even know what postpartum depression was. I figured I was just angry about my circumstances, but somehow I managed to struggle through depression after her birth. When I brought Lexi home, the stress became worse. I quit taking care of myself. I didn't feel worthy, and in my mind, taking care of myself meant taking time away from her. My daughter's father was there for me, but he was also an 18-year-old with little to no knowledge about how to raise a baby himself. I was terrified that I would feel this way forever, so I reached out to someone on my own to get help. I'll never forget the one time when I was feeling down, I talked to another mother who told me, in my day, we didn't have postpartum depression. We just had to snap out of it. She made me feel guilty and embarrassed, like I was weak and wanted the easy way out. She made me feel postpartum depression is not something you just can snap out of or deal with. It is a real problem with serious consequences if you don't help those that are in need, especially young pregnant mothers. Looking back, I clearly needed the help and was lucky enough to make it through without any interventions. Carriage House will provide knowledge and access to professional care to help with their mental health. We are respectfully requesting your approval of this one-time grant fund for the kids in this very difficult situation. The $2 million will be a historic help toward the $3 million cost of making this a reality. And if I would have had a place like Carriage House, I would have had the support, I would have had the access to resources given to me, and I would have been able to have help with my mental health. Any questions? Yes.
Are there any questions from the committee? Yes, Senator Walz.
Thank you, Cheryl Hansen. Thank you for coming today.
Thank you.
My question is, once the time is up, the 120 days is up, 90 or 120 days, and you're kind of out on your own, and you feel like you need support again,
Mhm.
what kind of follow-up is there? Do you,
So it's my understanding that once they're going to be given everything that they need to go out onto their own. That's what Bridges provides for everybody that need to do that independent living transition. With this particular program, it's my understanding that, or part of the program is my understanding that once they get transitioned out into independent living with all the resources, everything that the Carriage House is going to provide for them, we still will have individuals that can reach out to them for out placements or sorry, I'm very nervous, services once they've left our care. So it's just really the opportunity for them to help with that portion of their life that a lot of youth that are homeless don't have. So,
yeah, that's good to hear. Thank you.
Any other questions from the committee? Seeing none.
Okay.
Wait. Did you have a question?
No.
Oh, I think it's, I'm so used to asking you some questions. It must be just like unconsciously I look towards you.
I can ask that. I mean, I can come up with stuff.
Oh, no, there's seeing no more questions.
Okay, thank you.
Thank you very much.
Yes.
We'll take our next testifier in support. Welcome.
Hi. Good afternoon, Chairperson Hansen and members of the Health and Human Services Committee. My name is Rachel Steele, that is RACHAELSTEELE, and I am testifying today on behalf of young parents who need this support. It is my understanding that this bill will allocate funding for a residential youth parenting facility. I was removed from my home at 6 months of age and at 7 years old, placed with the family that adopted me into what should have been my forever home. However, I had very many placements from the age of 10 to the point I became a legal adult in Nebraska. I lived in TLC group home at age 16 when I was pregnant with my son. TLC was a facility that provided housing for pregnant youth and even included a daycare. The facility was preparing to close, so I was the only pregnant teen in the facility. And the option available to my child and I as this program closed was independent living, which meant figuring it out primarily on my own, how to be an adult and a parent. At the time I was leaving TLC and transitioning to independent living, I thought I was prepared. I was 16 years old, 7 months pregnant, and sure that I could do it on my own. And the staff at TLC were honest that this was not the best plan for success, but it was what was available. In my experience, had I had the guidance and support, such as the transportation, childcare, independent living, skill development with staff on hand, my son and I would have greatly benefited from that support. Being a parent when you're a kid yourself is challenging. I did not have the opportunity to have positive parenting role model to me, and I always felt like I was making it up as I went. I was not prepared to live independently, as I truly did not have the skills I needed. I was a kid trying to survive in charge of another life without the needed support. I was lucky that my firstborn son was a very easy baby, but the risk of postpartum depression is higher with first-time moms and those under 25 years of age. I've had 2 more children since then and experienced postpartum depression, and I could not imagine navigating that with my first son without support. There are many reasons a child has to leave their home, but when it is a child who is having a child, they deserve the resources to feel safe and to become adequately prepared to be a parent. Because I know how important support is during this transition, I urge you to advance this bill. Thank you for your time. Do you have any questions?
All right, thank you. Is this your first time testifying?
Yeah.
Did pretty good. All right, any questions from the committee? And you don't even get any questions either, so that's really extra good. All right, thank you very much, appreciate it. We'll take our next testifier in support. Welcome.
Good afternoon. My name is Tiba Alhaikal, TEBAAALHAIKAL. I was a youth at Cedars multiple times since I was 15 years old. My placements have always been short term, and Sirius was always a safe place for me to return to. They have taught me a lot and prepared me for adulthood. I have recently experienced not having anywhere to go with my 1-month-old baby at the time. And knowing the stress I felt, this carriage house would have been very helpful for me at the time. I believe this would be very helpful to a lot of young parents in similar situations. And I'm here for any questions you have.
Thank you for testifying. Are there any questions from the committee? Seeing none, thank you for coming.
Thank you.
Appreciate it. Take our next testifier in support.
Senator Hansen and members of the Health and Human Services Committee. My name is Dr. Eileen Vo-Travers. I'm speaking today in support of LB 772. I'm a retired pediatrician who practiced 31 years in Lincoln. I chose pediatrics as a specialty because of the opportunities it afforded me to prevent so many adult problems such as heart disease, obesity, mental health problems, and employment issues related to unrecognized and untreated learning disabilities.
Doctor,
From my
can I interrupt you really quick? Can you
Yes,
spell your?
my name?
Yes, thank you.
Eileen, Eileen. Usually that's what they ask for reservations at a restaurant too.
Yeah.
Vo-Travers, V is in Victory, A-U-T-R-A, V is in Victory, E-R-S. The long name allows me a few seconds more to talk today.
Yeah, thank you.
From my 31 years of experience and from 40 years of early brain and child development research by Harvard University, the value of prevention in terms of outcomes and return on investment cannot be equaled by any subsequent interventions or treatments later in life. As Benjamin Franklin said, an ounce of prevention is worth a pound of cure. LB 772 is unique in that it will support a statewide program designed to intervene at nearly the earliest possible time to prevent so many problems for not only mother and child, but society. Allow me to explain. Most teenage runaways and youth in the foster care system have had difficult lives and likely have high ACE scores. ACE stands for Adverse Childhood Experiences, of which there are 10. Examples of ACEs are experiencing in their home substance abuse, mental health problems, parental divorce, or incarcerated parent. Research has shown that youth with high ACE scores often have learning and behavior problems. The pregnant or parenting homeless youth served by this program most likely have high ACE scores and need stability in their lives. They need modeling in how to handle the daily routines of life and to handle emotions successfully. They also need guidance in navigating the challenges of their education. As a result of their success with these, youth develop resilience. Resilience is the antidote or treatment for high ACE scores. With resilience, youth are better prepared to lead more successful lives as parents, prevent their own children from developing high ACE scores, and be more successful employees. Without resilience, research shows that with increasing ACE scores, there is a significant increase in learning and behavior problems in young people. There's a similar significant increase in physical and mental health problems in adults when resilience is not developed. We have a unique opportunity by funding LB 772 to halt this intergenerational cycle of adverse childhood experiences as early as possible, and to halt the resultant learning, behavior, mental, and physical health problems. Research shows that a baby's brain development in utero is affected by a mother's nutrition, drug, alcohol, and toxin exposure, and her emotions such as anxiety or depression during pregnancy. In this program, homeless mothers will receive good nutrition, be in a healthy, safe environment, receive mental health services, and experience positive interactions, all of which have been shown to contribute to good brain development in a baby. So when mother benefits, indirectly the baby also benefits in these ways. In addition to providing services for mothers, babies of mothers in this program will directly reap lifetime benefits. Moms will receive evidence-based parenting instruction in how to provide the serve and return interactive experiences with their babies associated with stronger cognitive skills, language development, and fewer behavior problems. In summary, research has shown that the environment and experiences of a pregnant mother affect her baby's brain development, and the environment and experiences of a baby after birth directly affect the baby's brain development. The most fascinating and alarming research shows that the environment and experiences of a pregnant mother can also alters the genes of the eggs or sperm of that baby that she is carrying. These genetic alterations in those eggs and sperm cause the negative influences of mother's poor environment and experiences to be passed on and inherited by her grandchild. This is the negative intergenerational cycle that this program also intends to stop. The hope with LB 772 is to create a statewide program to intervene as early as possible in a fetus's life, to create a positive environment and positive experiences for maximal brain development in the baby, and to provide stability, modeling, and guidance for homeless mothers of those babies. As a result, those pregnant and parenting youth will develop resilience and be mentally healthy, contributing members of society. Healthy child development is the foundation for our community, our state, and our economic well-being. Thank you.
Thank you. I didn't want to interrupt you. It was actually interesting information. So,
Yes, thank you for allowing me to
yeah.
finish. Happy to
let's
answer
see, are there any questions from the committee? Okay. I don't know if you said in your testimony, you said you were a doctor of what?
Yes, a pediatrician,
That was it. Okay. All right.
yes.
Okay.
And I spent 10 years in my retirement studying the early brain and child development of Harvard's research and working on dyslexia legislation for those we got bills passed for that. So I appreciate the legislature's work on that. Thank you very much.
Appreciate it. We'll take our next testifier in support. Is there anybody else wishing to testify in support of LB 772? Welcome.
Thank you. Good afternoon, Chairman Hansen and members of the HHS committee. My name is Marion Miner, M-A-R-I-O-N, M-I-N-E-R, and I'm here on behalf of the Nebraska Catholic Conference, which advocates for the public policy interests of the Catholic Church and advances the gospel of life through engaging, educating, and empowering public officials, Catholic laity, and the general public. And I'm here to express support for the goals of LB 772 on behalf of the conference. And I'll shorten my testimony a little bit. I don't need to repeat what has been said. But these goals are in accord with the Church's vision for the advancement of a culture of life, which would welcome, protect, and support women, children, and families, as well as help them place their lives on a better trajectory. This also seems to us to be complementary to the efforts taking place already in our state, perhaps in some places more robustly than others, where private charities are providing women in these situations with protection, housing, and many other services until they can find a better situation for themselves and their children. Efforts in this direction are substantive expressions of solidarity with people who are vulnerable to abuse and suffering and have little or no assistance from family, which is often the case, as we've heard this afternoon. So we support these efforts and believe them worthy of the state's support, and I'm happy to take any questions if you have them.
Are there any questions from the committee? I have one. The Catholic Church has shelters or facilities that would qualify for this?
So that would, to answer that question, I would have to study that a little bit more closely in terms of what you would need to do to qualify. what type of qualifications you have to qualify for this particular program. There is a residential facility in Lincoln already, Catholic facility, where they take care of women who specifically are victims of domestic violence, to help them get away from that situation until they can find a better place. But that would be a little bit different situation, I think, than here
Okay.
probably.
And what's that place called?
It's called, they're called St. Gianna's Homes.
Okay,
Yeah.
that's right. Okay. Seeing no questions, thank you for your testimony.
Thank you.
We'll take a next supporter.
Good afternoon, Chair Hansen and
Welcome.
members of the committee. My name is Spike Eicholt, S-P-I-K-E. Last name is spelled E-I-C-K-H-O-L-T. I'm appearing on behalf of Voices for Children in Nebraska. You've got a copy of my written testimony. I know the committee's been here all day, so I'm not going to read it all to you. I just want to summarize some of the points. Voices for Children is an advocacy group that advocates for and works with children who are involved in the child welfare system and the juvenile justice system. You've heard firsthand today from people who would benefit from this type of bill and this program. And we want to thank Senator Hughes and the co-sponsors for introducing this. Some statistics just for you that others maybe have not said. Youth in foster care are 2 to 3 times more likely to end up pregnant. And some statistics have that up to 50% of girls who are in foster care are pregnant by the age 19. This would benefit children who are system impacted, who have experienced trauma. If they don't have a place to stay, if they don't have a place to go, then you have pregnant and parenting teens who will either be on the street or be in some other place where they're not safe, where they're not supported, where they're not sober possibly, and they'll end up getting system involved all over again, or perhaps even worse. This is a very good bill. I urge the committee to advance it and support it. I'll answer any questions if you have any.
All right, thank you. Are there any questions from the committee? Yes, Senator Kemp.
I've just been waiting for years to be able to question Mr. Eicholt, so I just thought I would, now that you're here. How are you?
Fine.
That's all I got today, but maybe next time I'll have more. Thank you.
Thank you.
Any other questions from the committee? All right, seeing none, thank you. Is there anybody else wishing to testify in support of LB 772? All right, seeing none, is there anybody who wishes to testify in opposition to LB 772? Is there anybody who wishes to testify in a neutral capacity to LB 772? All right, seeing none, we will welcome up Senator Hughes to close. And I believe, yes, we do have 2 letters in support for LB 772, one from the ACLU of Nebraska and the other one from Carol Dennison, who's representing herself. And actually there is another one in a neutral letter from the Department of Health and Human Services. All right, thank you.
So Senator Hansen, members of the committee, thank you. I urge you to report LB 772 to the general file. I also urge you to take a tour of Cedars right here in Lincoln, which has a 75-year history of preparing at-risk youth for success by support and training to become productive members of our communities. They are doing the outreach to our at-risk youth, bringing them in from the streets, diverting them from jails, and propping them up when no one else would. I took a tour there last month and was floored by the amount of work that they do there. And despite the discouraging fact that some of our youth face tremendous obstacles, I was highly impressed and encouraged by the work that they do. I was even more impressed by those young people that I'd met, the smiles on their faces, and the young man who ran to make his bed before he would show me his room. I wish my son would do that sometimes. As our governor stated when he took office last month, we can never, ever give up on our children. Thank you, and I look forward to seeing LB 772 on the general file.
Thank you. Are there any questions from the committee? Yes, Senator Reapy.
Thank you.
Uh-oh.
Senator, good to see you. Thank you for being here. Is Cedars a tax exempt 501c3 organization?
I believe so, but I can get back to you 100%.
My guess is.
Yes, they are.
I guess,
I
maybe
assume
this
so.
is less of a question, more of a concern is, it used to be that when community projects would be there, we would rally and have a
Fundraiser.
community-wide campaign to raise
Well,
money.
and
And it seems now more organizations turn to the state
sure.
for fundamentally taxpayer monies.
Sure.
And this has been somewhat true. I'll pick on Lincoln here a little bit because we have, Madonna coming for money, others,
But I understand that, and I think.
and we don't see that so much from outside of Lincoln. I'm sorry for those of you who live in Lincoln, but that's the way I see it.
Yeah. For the record, the facility, they're not asking for full funding of it. So I think this could be used as money to get matching funds when you fundraise. And then second, I think, and I guess you could argue it with all nonprofits, right? A lot of nonprofits take money, they're saving the government money because I'm part of many nonprofits, are doing things, like they said, down the road. If we don't do something with this mother and the child, it's potential that they will be on the back of the government the rest of their lives. So if we can get them upright and on their own and contributing members of society, that is saving us money down the road. And that's how you can look at it that way. But that's a lot of the nonprofit work that is done. So I totally see that.
I appreciate you being here and for taking this cause on.
It is a good one, but I know there's many good ones out there. So
Well, thank you.
yeah.
Senator Kavanaugh.
Thank you. I just wanted
Sure.
to go back to, it was govdeals.com and the property sold for $313,000.
I'm like, wait a minute. I'm like, what
Yeah,
is Govdeals.com, the property in
The Geneva campus
Uh-huh.
and farm ground sold for $313,950. And that's less than what they spent to renovate one of the buildings during the YRTC disruption of 2019. I know, right? It's unfortunate. And they also lost a lot of jobs there. So I'm really just doing the advocacy work here that Senator Brandt probably would do if he were sitting on this committee right now.
Yep.
But yeah, govdeals.com is where apparently you can buy government
Really cheap
property, real cheap property.
Good deals.
I very much appreciate Cedar's work and thank you for bringing this bill.
Absolutely. And I will, and to piggyback that a little bit, it is a little bit about location. And what's nice about Cedars is they've got an established place that they can, so when we went and toured it, this part of the facility would be still on that main campus, but off a little bit. So they kind of feel like they are living in they're not just part of the residential program. They're a little bit off, starting to learn those skills. And it's just kind of that bridge point then to get them off into the, offsite actually on their own with still some support. It's just kind of that in between. And so that's where it's like the Geneva place wouldn't work for this because they've already got the people there that are staffed and all that. But I mean, you guys know that.
I will add, no, the Geneva obviously would not work for this because it's attached.
But
to
that is a shame.
But the Geneva campus did have a chapel, a high school.
Really?
It had a farm. It had multiple cottages, one of them newly renovated. It was very nice.
So I wonder what that person that bought it's going to do.
I don't know, but I
Maybe
sure
it'll be
hope
like
they invite
summer
us.
camp. We could like legislative summer camp. That'd be fun.
Thank
Anyway,
you.
Sorry.
Hughes.
Okay.
I don't think any of us are buying it on our salary. Any other
What?
questions?
Yeah, right. That would way outprice us. Anyway, sorry.
I'm a little surprised that what Mr. Eichel shared about the data with youth and foster care and the pregnancy rates.
It's sad, isn't it?
Pregnancy at 2 or 3 times the rate of the general population, and is estimated that 50% of girls in foster care will become pregnant by age of 19. So facilities such as Cedar, do they do any kind of education at all? Like when somebody comes in about, it's like sex education or, along with helping them,
I know they do a lot of training, just life, and I would imagine that. Yes, we're getting the big nod. I would imagine so.
Yeah, it's kind of curious. It's kind of a shocking statistic.
That is a shocking. It's very sad because then
And
that's for another conversation.
to not build up Gov deals too much. There's another one called Gov Planet that Senator Brewer always shows me all the time. But you can buy a Hummer on
Planet?
there. So
It's like government merchandise that you can buy. I gotta get on these.
Yeah, I just didn't want to show favoritism to one website over another.
Okay,
so.
fair enough.
Yeah, okay. Any other questions? Seeing none?
All right.
Thank you very much.
Thank you, guys. Thanks for your time. I know it's been a long day.
And now close the hearing for LB 772, and then we will. Is it mine next? Okay, and then we're going to open it up now for LB 227.
Yeah.
Okay.
Oh, you want me to?
Benson, can you give her the letters of support in opposition?
Welcome.
Thank you.
Senator Hansen. Chairman Hansen.
All right. Well, good afternoon, fellow members of the Health and Human Services Committee. My name is Senator Ben Hansen. That's BenHansen, and I represent District 16 in the Nebraska Legislature. I'm here today to introduce LB 227, a bill to direct the Department of Health and Human Services to reimburse hospitals for nursing facility level of care services when Medicaid patients remain in hospital beds with no place to go. I am also introducing an amendment to the bill to clear up confusion about what hospitals are eligible for reimbursement, what patients are included, and where the funding comes from. For those of you new to the committee, last fall, this committee held a hearing on LR 417. It was an interim study that provided a greater look at the challenges facing staffed bed capacity at hospitals in Nebraska, including the challenge of hard-to-place patients. With the inability to transfer patients to the appropriate level of care, some patients essentially live in hospital rooms, receiving care and taking up precious bed capacity with no compensation provided to the hospital. These difficult-to-transfer patients may have mental health problems, physical disabilities, alcohol and drug abuse, function poorly, and have a greater need of care, or they may have a combination of all these problems. This means that hospitals are housing patients who need care but don't need to be hospitalized, denying other patients with immediate needs. They are receiving no compensation for the bed, room, equipment, staff time, food, and medications. There isn't a quick fix to finding a solution for difficult-to-transfer patients, but there are a handful of bills in front of our committee that are trying to address the problem. LB 227 and the amendment will direct DHHS to pay hospitals 100% of statewide average nursing facility per diem rates for Medicaid patients eligible for discharge remaining in their care. It does not cover the cost of the daily hospital rate, but if hospitals are required to care for medically complex Medicaid patients, they should receive some compensation in return. It is important to note that this amendment also ensures that funding is contingent on federal approval from CMS. Thank you for your time this afternoon. I'm happy to answer any questions, but there are healthcare experts behind me that may shed more insight on the difficult to transfer patient challenges.
Thank you. Questions from the committee?
Should we wait to go to the fiscal note? I'm sorry.
Senator Repeat?
Should we wait to go to the fiscal note?
There might be better healthcare experts behind me to better answer your questions and shed more light on those questions.
Well done. Thank you.
Any other questions? Thank
I'll
you.
stay to close.
All right. Thank you. First proponent.
Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. My name is Dr. Lisa Vail, Lisavail. I'm the Vice President of Patient Care Services and the System Chief Nursing Officer for Bryan Health, a locally owned and governed Nebraska hospital system comprised of 6 medical centers. I've been a registered nurse for over 40 years, and I come to you today on behalf of the Nebraska Hospital Association in support of LB 227. A patient's qualified inpatient episode of care is paid for via what is called a DRG, or Diagnosis-Related Group Reimbursement. This is a fixed amount payment based upon an ICD-11 code assigned for that diagnosis, not based on the direct cost of providing care. For example, utilizing easy math, if a patient is admitted to a facility for pneumonia, assume the DRG payment would be $10. If a patient with pneumonia is admitted for 2 days and the cost of care is $6 a day, then the hospital loses $2 on the cost of caring for that patient over the 2-day stay. Every day the patient is in the hospital past those 2 days, no reimbursement is received for the care of the patient, resulting in greater financial loss while we are still providing for that patient. This week at Bryan Medical Center, we have 11 patients with lengths of stay over 100 days, including one patient with a stay of over 480 days. Our direct cost per day for room and board is on average about $1,000. This fluctuates slightly when labor and supply costs are higher. When patients experience barriers to discharging to the next level of care, every day they stay in the hospital in excess of the DRG approved length of stay is a day that the hospital is not reimbursed. If one patient is in the hospital 15 extra days, the point of medical necessity, beyond the point of medical necessity because of barriers to a placement in a long-term acute care hospital or a rehabilitation, assisted living, skilled nursing, or long-term care facility, that's $15,000 of unreimbursed costs to the hospital. Multiply that by 10, 20, or 50 patients, and you can see the significant challenge this poses in our hospitals. In the case of our current patient sitting at a length of stay of over 480 days, who still doesn't have placement at the appropriate level of care and will continue to be in our hospital for the foreseeable future, this is almost $500,000 of unreimbursed care for one patient who no longer even requires our acute care services. This figure will continue to grow as they await post-acute placement. It is our mission to care for those who need us and to ensure that they have every resource needed to be safely discharged. When barriers to discharge are present for so many patients, it limits our ability to fulfill our mission and care for everyone that acutely needs our services. LB 227 provides assistance in filling this gap. It does not cover the direct costs of patient care entirely, but serves as a support to the hospitals and as an incentive for insurers to get the patient to the appropriate level of care in a more timely manner. LB 227 will not fix the complex case placement challenges in our state. This bill is a piece of the patchwork of solutions that are before the legislature this session. Yesterday, you heard testimony on LB 353, today on LB 227, and will on 517. It will take approaching this issue from a variety of angles to completely solve the crisis. LB 227 will provide support for hospitals as we seek the right level of care for our patients, some of which wait between 100 and 400 plus days for placement. I am grateful for the opportunity to give you a glimpse of the challenges our Nebraska hospitals and the patients, friends, and neighbors we mutually serve face. As you hear from myself and others later today, I ask that you be moved to take action in support of LB 227. Thank you for your time, and I'm happy to answer any questions.
Thank you so much. Questions from the committee? Senator Ballard.
Thank you. Thank you for being here. Can you describe some of the barriers that are experienced in placing these patients?
There are very many and multiple. I would say homelessness, patients who are deemed non-decisional, therefore guardianship issues come into play, and there aren't enough guardians in the state of Nebraska. And once a patient goes on that list, we can wait months and months for them to get to the top of the list for OPG. We have waiting for Medicaid eligibility for payer source because post-acute providers will not accept a patient until there is a decision maker, a legal decision maker, and a payer source. We have bariatric issues or patients who are very large, who are difficult to handle. We have mental health and behavioral issues. We have seen sex offenders, illegal immigrants who have no pathway for payment in the United States of America because they're not citizens. So these are just some of the different types of barriers that we see.
Thank you.
Any other questions? Senator Rigby.
I have a question for requesting clarification, I guess. The issues as you've described it, and I understand that hospitals get, for lack of a better term, stuck with patients who they can't place out. So I'm a little bit surprised that the fiscal note looks like it's 3.5 million in year one. I'm surprised it's not more like 305 by the time you look across the entire state of Nebraska.
Mm-hmm.
And when everyone starts sending in their tickets, I mean, this might be chump change. as we get started.
Mhm.
So that's why I'm interested in the fiscal. Now,
Sure.
I rarely say that I don't think it's enough, but it's probably not enough.
Mhm. I would agree with you.
Oh, well, okay.
Any
Thank
other, any other questions?
Thank you.
Thank you.
Hmm? Oh, they got liberal. I heard they got liberal for a while, but coming from you, that's a compliment.
Good afternoon.
Okay, good afternoon, Chairman Hansen, and good afternoon, members of Health and Human Services Committee. My name is Dr. Kerry Ward. I'm the Chief Medical Officer for CHI Health, and my name is spelled Caryward. We're much in the same boat as Lisa Vale mentioned. Before I get to that, I want to say just a little bit about our system. Our Midwest Regional Division consists of 28 hospitals, 2 standalone behavioral health centers. We have 12,500 employees, 1,100 employed physicians and advanced practice providers. We're in Nebraska, Iowa, Minnesota, and North Dakota. And I'm here today representing CHI Health, the Nebraska Hospital Association, and the Nebraska Chamber of Commerce and Industry, whose Healthcare Policy Council and Board of Directors recognizes the need for adequate Medicaid reimbursements for our hospitals and skilled nursing facilities. Thank you very much for the opportunity to express our support on behalf of LB 227. So every day at noon, I co-lead a call with all of our presidents of our hospitals in Omaha and Lincoln to look at long lists of patients that are needing transfers out of our hospitals while looking at a list of patients that are trying to get into our hospitals. And about 10 to 20% of our patients at any given time do not have a safe and suitable placement for discharge. Our care management, our discharge planning team diligently calls. We even have an expensive software program, ADA, that tries to send these messages out within a 250-mile radius, trying to get placement for our patients to find some facility that would take them. We, of course, continue to care for these individuals while trying to find these places, but it extends their stay in the most costly site of care and also delays their recovery. So we keep track of these numbers, and in the past year, our CHI Health Nebraska hospitals recorded 29,079 hospital days that were defined as avoidable delays, meaning the patient was medically ready for discharge to the next level of care, but a suitable placement option did not exist. This is significant because, as Lisa well described, Medicaid reimburses based on the DRG system. So if acute care is no longer deemed necessary, but we're unable to secure post-acute placement, we're left in a precarious position. This is also significant because well over 800 patients stayed longer in our hospitals than was medically necessary last year. These delays also impair our ability to accept new patients. On any given day, we may have 20 plus patients in any one of our EDs that are ready to go up to the floor to be admitted, and there's no place for them. And we may have 10 patients on our transfer list to accept at any given time to try to get into our hospitals. And with all of these patients in our beds, we have difficulty finding placement for them. So just one example. So Lisa mentioned an example. We have a very similar example. We had a patient that stayed 785 days. This patient, during one of their stays, was in for 222 days. They were in so long because they had behavioral cognitive issues that required one-on-one care, and none of these facilities were able to take the patient. So for these 222 days, Medicaid only covered 8 of those days. So 96% of their stay resulted in uncompensated care. These are referred to as difficult to place patients, multifactorial, as Lisa mentioned, and requires a full complement of strategies, but this is just one strategy because it provides a reasonable per diem rate. Whether it's 100
or we just heard. For the reimbursement we receive, we are responsible for providing care to the patient to meet their short-term urgent medical needs. The problem is that once we stabilize the patient, we have no control over whether or not there is available post-acute facility willing to accept the patient for their next level of care. As these medically stable patients are awaiting to transition to post-acute services, our health system receives no additional funding to continue their care. Approximately 18% of our patients in our hospitals awaiting discharge are insured by Medicaid. In the past year, our Medicaid patients accrued over 4,500 avoidable days. This is just our Medicaid patients, which are days that, as Dr. Ward said, are ready to discharge, medically stable, but they remain in our hospital. These avoidable days for Medicaid patients added about $3.3 million in uncompensated care costs on top of the already low reimbursement rates, which typically only reimburses 88 cents for every dollar spent on caring for a Medicaid patient. LB 227 is an important part of the solution to this healthcare traffic jam. It will help our hospitals cover some of the uncompensated costs associated with providing longer-term care to patients as they await transfer to post-acute settings. Our health system is facing one of the most difficult financial situations in recent history, with the combination of skyrocketing expenses, significant staffing challenges, more complicated patients, and longer lengths of stay. In the last 2 years alone, our health system's labor costs are up over 20%, with an increase in the cost of contract labor of 941%. Supply costs are up 19%, and the cost of drugs increased by more than 20%. This additional reimbursement in LB 227 will be meaningful during this very difficult financial time for not only the urban hospitals or these larger hospitals, but also other hospitals across the state. What is also important about LB 227 is the structural incentives it creates to ensure we will all be working to move the patient to the right level of care. Our hospital still maintains an incentive to try to move the patient to a lower level of care because although we are being reimbursed something, the reimbursement amount in LB 227 will not fully cover our costs. It also provides an incentive to our state's Medicaid program to ensure that post-acute facilities accept transfers for Medicaid patients because it would be more cost-effective for the state to get the patient to the appropriate level of care. LB 227 ensures that financial incentives are aligned with what is best for patients. Hospitals have little control over who comes through their doors seeking care. We are not allowed to deny patients medically necessary care if they have no insurance or are underinsured or no legal guardian. It is embedded in our mission to extend serious medicine extraordinary care to all Nebraskans. We also cannot control how and when patients leave our hospital because we rely on these post-acute facilities to accept patients who are ready to discharge to a lower level of care. It is in the best interest of all stakeholders, patients, hospitals, policymakers, to ensure that we are creating efficient transitions through our healthcare system and ensuring continued access to acute care. Doing so will improve patient health outcomes, reduce uncompensated care costs, and ensure patient choice and access to the right type of health care at the right time. Thank you for your consideration, and I'd be happy to answer any questions.
Thank you so much. Senator Reed.
Thank you.
Yes, it's not.
At one time, hospitals were, for accreditation, were required to have written transfer agreements with nursing homes. Is that still the case?
I believe so, and we do have.
And that's obviously not working because those 77 that you have, you said you're not, so the transfer agreement sounds like it's null and void.
No, I would say that the 77 have complex issues like Dr. Vail mentioned, and so the facilities are unable to care for them because they either don't have the specialized trained staff or they don't have the right type of bed, or in the sex offender issue, they can't take them in those areas, or the patients are what we call incapacitated and they need the public guardian, and so we're waiting months for them. So some of them fit into that complex group.
So, well, in concept, it sounds like problem solved, but it's not the case because it doesn't function.
It functions.
Acuity of the patients.
It functions sometimes. It does function sometimes. And I would also state that the post-acute facilities are experiencing workforce shortages just as we are in the acute care setting. So sometimes they don't have enough staff to care for the patients.
Second, if I may, Chairwoman?
Yes.
Okay, thank you. The second one is given a choice, would you prefer to have this block grant or would you choose to have rate increases?
Oh, my goodness gracious.
Time's up.
Yeah, I would want to give that a little bit more thought, to be honest. And to your previous questions of the other
This
speakers,
is not Jeopardy.
this is not enough money. And however, there are several other bills that are asking for money. So I think we're trying to be good financial stewards and asking for some and not asking for everything here because there are other requests that we have.
The one asking for money is probably going to the Revenue Committee, which is a much easier committee than this committee.
Well, then I think maybe I need to go to that committee.
Okay, thank you for being.
You're welcome. Thank you.
Other questions? I have one, and
Yes.
it might be kind of a big question
Oh,
to
boy.
answer. But, you know, obviously, this is a big problem.
It is.
We had an interim study last summer, and you can see the bills that we're trying to bring forth today to try to address the problem. But considering that, you know, this is such a huge problem and it involves so many people, DHHS, guardians, hospitals, nursing homes, behavioral health. Has there been an effort to bring all of those, and I know that's part of our process, but on the healthcare side, is there an effort to bring all of those entities together and devise a plan that you could bring forward?
I would say there is. Nebraska Hospital Association has graciously pulled all of us together over the last, they're in the back there, maybe 2 years, 18 months to 2 years. And it's been facilities from across the state. So it hasn't just been the larger urban hospitals. It's been hospitals across the state that have come together. And some of the recommendations that we put forward came from that group within from the NHA.
Okay,
So we can continue to do that if you think that would be most helpful.
I do. Senator Reefy.
Oh, my goodness. Yes. It's my time up. Oh, there's no red.
Yeah, I think you resent this or afraid. My question would be back is within Medicaid, you know, do they have their priorities not in order in the sense that in the process of building new programs, they're not funding the programs they already have?
I appreciate that question. I'm not sure that I have enough information to answer that right now. I would want to do a little more investigating before I could truly
You
answer
should run
that.
for politics.
No, thank you.
Thank you.
You're welcome.
Any other questions? I don't see any. Thank you
Thanks.
so much.
I'll be
coming.
back.
Thanks. Oh, next proponent, sorry. Any opponents? Anybody that would like to speak in a neutral capacity? Come on down.
Good afternoon, members of the committee. My name is Kevin Bagley, Kevinbagley. I'm the director of the Division of Medicaid and Long-Term Care within the Department of Health and Human Services. Here to testify in a neutral capacity for LB 227, which, as you all have heard, reimburses hospitals for the nursing facility level of care to a patient who no longer meets that inpatient level of care. So I'm going to try and keep my comments a little bit more brief. I know there are questions. And so in the interest of time, I will try to keep them brief. I want to thank Chairman Hansen for the opportunity to meet with him to discuss the bill and some of the department's concerns that we saw with the green copy. We also appreciate his willingness to work with us on potential amendments. My comments today are primarily on the green copy, but I'm happy to speak to the amendment as well. To be clear, we recognize the need to facilitate more efficient transitions for care for patients ready to leave hospitals. As you've heard, this is a pretty substantive and complicated issue. And so I want to make sure that you all hear from us at the department that we recognize that. LB 227 sets the rate of reimbursement at 150%, and the amendment changes that to 100% of the statewide average nursing facility per diem rate. This is similar in terms of the service category definition to what our partners at the federal level would call a swing bed. Swing beds are typically available in rural hospitals with fewer than 100 beds, but it is paying, excuse me, paying for a nursing facility level of care for an individual who still is at a hospital. Using CMS's definition and requirements around swing beds, it would limit just to rural hospitals and would, by default at that point, inhibit hospitals in Lincoln and Omaha or any rural hospitals with more than 100 beds from participating unless we had special federal approval. Absent that federal approval, we would be required to expend all state dollars. The green copy initially would have us seek that authority through the existing 1135 waiver. The technicality aside, that is an emergency declaration waiver that gives states flexibility on how we administer these. According to what we've heard from our federal partners, that will expire in May. By addressing some of these issues and bringing the bill into compliance with existing federal requirements, we would effectively be requiring the department to pay for swing bed services, which we currently already pay for. But like I mentioned, that would preclude our hospitals in Lincoln and Omaha from receiving that payment. And we've heard from them, particularly today, that they experience this issue just as much, if not more, than any of our other hospitals. We remain committed to addressing the multifaceted problem of hospitals struggling to discharge patients. And we are open and continue to work with our hospital association, our nursing home association, legislators, patients, and other community stakeholders to address these issues. We welcome those conversations. We're committed to facilitating efficient, safe, and orderly transition of care for patients who are able to leave our hospitals. Appreciate the opportunity to testify today. Happy to answer any questions, including Senator Reapy on the fiscal note.
Might get one.
I might.
Senator Reapy.
Thank you. Even within DHHS, it's been described as a very generous state Medicaid program, which I take some exception to in the sense that I believe in Medicaid. I just don't think it should be the platinum health plan. And it seems to me that you've been busy expanding Medicaid while failing to support those that already need support. Like, you know, we're bringing on new programs, be it dental, be it behavioral health, be it whatever, under the philosophy that we want every federal dollar we can pick up by giving as many programs as we can give. And yet we're failing on the other side of not taking care of the programs that we already have. That was an easy question. I have some tougher ones.
Well, I'd love to hear what the tougher ones are.
Oh, you might.
I'm sure I will. You know, without trying to speak to some of the other elements of the Medicaid program, I think on this front, I will say a lot of the complication with this does not come from a lack of willingness on the part of the Medicaid program to pay for the services. It comes from a federal regulatory apparatus that makes it incredibly difficult to navigate these waters. And it puts the burden pretty squarely on our hospitals to deal with. You heard from them that their part of their mission and part of their requirements are to take patients, regardless of ability to pay, regardless of some of the complicating factors that they experience. Our nursing homes are in a position where the federal regulatory apparatus makes it very difficult for them to discharge someone once they've been admitted. And for a lot of these patients that need that lower level of care, it puts all of the downside risk on our nursing homes without giving them any real incentive to navigate that. And I think this reflects, and Senator, you'll appreciate a good soapbox moment. This puts us in a position where we are really unable to administer the level of long-term services and supports that we need to. And it puts the state in a position where we're unable to provide an apparatus that works in a way that our patients need. So I will say we are willing and able to put in a request to our federal partners for this type of authority. We put in a similar request during the pandemic to receive Medicaid dollars to help facilitate some of these transitions or to allow patients to stay in the hospital. We were flatly denied. That doesn't give me a lot of confidence that we'll receive federal approval for this type of request, but we are committed to helping ease this burden and make this process work more smoothly. And so as I've shared with others in conversations, we're happy to make the request.
It sounds to me like the providers, though, don't want more management help. They want more financial help.
I would say that's,
it's just the process is there. It's just not the fuel, not the money to make it happen.
And I would,
to me, that is setting priorities within Medicaid that says what pieces do we have to feed to support to make sure that they're meeting the minimum standard before we take on more new programs. That's my concern.
and I think that's fair, Senator. I would say this one falls squarely into the realm, I think, of where our federal partners have put us between a rock and a hard place in terms of what we are able to do. And I'm happy to work with anyone on resolving that, but I don't even think in this case the money is the issue.
But I think the hospitals and the nursing homes feel like they're between a rock and a hard place.
I absolutely
so there must
agree.
be a lot of rocks out there.
I agree, and I think most of them say CMS, property of CMS on them.
Yeah. Okay. Thank you, Chairman. Thank you.
Of course.
Thank you. Thank you for being here.
Thank you, Senator.
Any other tough questions?
She put me on the spot. Thank you for being here, Ms. Bagley. Kind of piggybacking off of Senator Reeby's questions, the last testifier, this doesn't solve the problem. This is a symptom of the problem. For those of us that were not on the interim study last year, if you have a silver bullet, what would you tackle? What would you?
Trying to think of how I express this without going on a 20-minute soapbox, Senator. I apologize. I think the silver bullet is, and I don't even know that I would call it that. I think the solution needs to come down to really thinking about how we support every facet of the continuum of care. And the way that the regulatory apparatus at the federal level in particular is set up right now, it penalizes some providers for trying to solve problems that are difficult to solve. So an example of that may be dealing with behaviorally complex patients who are just difficult to care for and have a lot of complicated issues. If our nursing homes take on too many members who have co-occurring behavioral health conditions, then they may fall subject to regulations that preclude them from being a nursing home and tell them that they're an institution for mental disease and that now they no longer qualify for Medicaid dollars. And so there is just this web of regulations that try to deal with aspects of that continuum, but they lose the forest for the trees, if I can put it that way. Maybe I've muddied the water more in trying to comment on that, but I think really what it comes down to is we're hearing a symptom of the problem. And the underlying problem is that the continuum of care, particularly for our long-term care patients, is broken. And I don't think there's an easy solution to it. And if I'm totally honest, it's usually not an issue of no one's willing to pay for it. It is an expensive continuum of care, but there is a lot of money already being allocated to this continuum of care. But a lot of it goes to dealing with a regulatory apparatus that really isn't focused on the continuum. It's focused on individual elements of it.
Okay, thank you.
I'm sorry, I hope that wasn't a confusing answer, but it's a complicated problem.
Yeah, of course.
Senator Reeve.
Well, it's a softball.
All right.
A few years ago, there was a movement towards block grants, which quite frankly, I would like to see you empowered, or us empowered, to decide where we want to spend the money rather than get dictated that to get B, you have to give me A, from the federal standpoint. I take exception to that. We know better where we need to spend our dollars to get what we want. So, see, that was fairly nice. I want to leave on a nice note.
And I appreciate that. I think the ability of the state to be flexible in addressing the specific needs of our population.
Is there any more discussion on black grants?
I have not seen a lot of movement at the federal level.
That's what happens when you get white hair. You've been around long enough to hear about some of these things.
And someday I hope to know what color my hair will actually be.
I didn't really need to offend in any way. Thank you.
Any other questions? Thank you so much for being here today.
Thank you,
Appreciate it. Any other in the neutral capacity? All right. Where's Senator? Okay. We did have 3 letters, 1 proponent and 2 opponents.
Okay, I'll try to address some of the questions that we had, but the previous testifiers brought up some good points about why we're in this shape that we're in and why we have so many patients stuck in hospitals instead of post-acute care facilities. And I think Senator Walz, you kind of brought up that we are trying to address this with different bills. We got together. There's some other senators who are bringing in different bills to address like guardianship, the facilities, the infrastructure of the facilities and stuff like that. So it's not kind of a silver bullet type approach. It's somewhat like a shotgun. It takes a lot of different spots to correct. And it is, I think what Mr. Bagley said about, and I think even Senator Ballard was addressing it, is like this is kind of addressing the symptoms. And I'm a fiscal conservative, and I'm not a big fan of fixing symptoms and trying to actually just fix the cause. However, I think this bill is appropriate if we're going to spend taxpayer money on something, and if we're going to force somebody to take care of people. I think it's only just that we help them take care of those patients financially. And to remember, these are Medicaid patients only, and I think the average cost per day for a Medicaid patient in a long-term healthcare facility is $294. And the fiscal note is off because it's from our original bill and not the amendment. The amendment changed the swing bed part of it. And so more hospitals will be eligible for this. And also the fiscal note had it at 150% instead of 100%. So that will lower it too. So it's going to go up, but not exponentially. And this is, to remind you, it is contingent upon federal approval. So we haven't even been approved for this yet. We can pass this and put it out there and the federal government says no, and then nobody gets anything. But I think when we talk about addressing the symptoms, I think the underlying cause we also have to do is address the education of our citizens about living a healthier lifestyle so they don't end up in these facilities in the first place. Having a proper support system in place that's fiscally responsible, and also encourage personal responsibility. I think those 3 things kind of collaborate to to address symptoms instead of just kind of throwing money at a problem. So I know we're just addressing the symptoms with this, but I think it is appropriate, along with some of the other bills that have to deal with the overlying issue of why these patients are in hospitals. So with that, I will take any questions.
Questions?
Oh, I got scot-free. All right. Okay. Well, thank you very much.
Oh, we're going to close on LB 227 and open on LB 434, Senator Jacobson.
Welcome, Senator Jacobson.
Thank you.
You notice how a whole bunch of people in the committee left?
I noticed those who were the weak ones.
You
on the
scared them
committee.
last time.
And I specifically took my tie off today. I think it was a little tight yesterday in my clothes, so I thought I'd not wear one today.
That was it. Well, welcome.
Well, good afternoon, Chairman Hansen and members of the Health and Human Services Committee. My name is Senator Mike Jacobson, Mikejacobson, and I represent District 42 in the Nebraska Legislature. I'm here today to introduce LB 434, a bill to require the Department of Health and Human Services to enroll long-term acute care hospitals as providers under the Medical Assistance Program. Long-term acute care hospitals are facilities that specialize in the treatment of patients with serious mental conditions that require care on an ongoing basis, but no longer require intensive care or extensive diagnostic procedures. These patients are typically discouraged from the intensive care units and require more care than they can receive in rehabilitation centers, skilled nursing facility, or at home. In Nebraska, this level of care is provided at Madonna and Select Specialty Hospital in Omaha. Without this care available in Medicaid, patients receive rehabilitation services in acute care hospitals that are not designed to meet their specialized rehabilitation needs. This also takes additional resources away from acute care hospital capacity, which explains my interest in this bill. The Nebraska Hospital Association asked me to introduce this bill because the hospital in my district, Great Plains Health, has experienced patients taking up bed space in their hospital when they could be much more appropriately cared for in a long-term acute care hospital. Ensuring the long-term acute care hospitals receive Medicaid reimbursement would allow for more long-term acute care patients to be transferred to the appropriate level of care, freeing up precious bed capacity in hospitals. Due to the healthcare workforce shortage, hospital bed capacity across the state is extremely limited. We need to consider all options like LB 434 to help hospitals free up bed capacity and to make sure we are best caring for the patients in Nebraska. Again, I would just tell you that you've heard a long litany today of bills that are really designed at how can we help fix this medical problem. I will tell you that I'm very concerned, particularly in rural Nebraska, about the loss of nursing home facilities and the loss that we will see of rural hospitals if we don't do something more than we're doing today. Rural hospitals, just go look at the numbers. Very few rural hospitals were profitable in 2022. We will be losing those hospitals if we don't adequately fund them and provide them with the resources that they need to be able to deal with patients and to be able to cover their costs. And so I thank you for your time, and I will hang around for the close, and I'll defer for any questions.
All right, thank you. Are there any questions from the committee? So I like how you get the fiscal note that says 0 on it.
Well, I don't know whether that had anything to do with my clothes yesterday or not, but I'm happy with the 0.
Okay, all right, seeing no questions. We'll welcome the first testifier in support of LB 434.
Chairman Hansen, members of Health and Services Committee, thank you for allowing me to speak again. Again, my name is Dr. Carey Ward, CARYWARD, CMO for CHI Health. I've already described the challenges in navigating patients to the appropriate level care under LB 227. I'll keep my comments very brief. The issue of expanding access to appropriate level of care requires a variety of solutions, including building capacity within our long-term care acute hospitals. LB 434 acknowledges the need for a favorable reimbursement environment so that the long-term care acute acute care hospitals can accommodate the current demand and forecasted increased demand for long-term acute care services that an aging population requires. These hospitals share many of the same workforce and rising cost pressures that our acute care hospitals do. In order to provide the best possible care to patients at the right time and at the most appropriate care setting, we must fortify each component of the healthcare continuum. If long care hospitals are operating in the red and unable to staff beds, our hospitals feel that impact, manifest in the number of patients who are medically ready to transfer to long-term care, but for whom we're unable to find placement. So last year, our Nebraska hospitals recorded over 3,000 hospital days where a patient was medically ready for discharge to a long-term care hospital, but was unable to successfully transition to the next level of care, possibly due to a lack of capacity or other delays. This constitutes about 12% of our hospital days in which we were unable to discharge patients. So LB 434, coupled with several complementary bills, that will be presented next, I know. Each offer distinct and essential solutions to a complex and urgent healthcare capacity challenge that adversely impacts patient care and experience. In closing, I'd like to thank Senator Jacobson for introducing this bill and the Health and Services Committee for your support in strengthening the continuum of care services in Nebraska. Be happy to answer any questions.
All right, thank you. Are there any questions from the committee? Seeing none, thank you. Take next, testify in support. Welcome.
Thank you. Good afternoon. My name is Chris Lee, CHRISLEE. I'm representing Madonna Rehabilitation Hospitals, and I'd like to thank Chair Hansen and the other members of the committee for this opportunity to speak before you regarding LB 434 rather. I'm the Vice President and Chief Operations Officer of Madonna, and we're a not-for-profit organization that provides medical and physical rehabilitation to patients from across the U.S. We operate 4 hospital facilities that have varying certifications, but today I want to focus on the 2 specialty hospitals that really focus and specialize on caring for patients with critically ill, complex medical needs. These hospitals are licensed in the state of Nebraska as general acute care hospitals, but certified by the Centers for Medicare and Medicaid as long-term acute care hospitals. For these hospitals to maintain their LTAC certification, they have to maintain at least a 25-day average length of stay. Ours is a little over a month. And they have to show that a majority of their patients are either on a ventilator or have had a stay in an intensive care unit in an acute care hospital. So these hospitals are specifically designed to care for some of the sickest, most complex patients that are going to require a very long time to recover at a hospital level of care. And so LTACs fill an important role in the continuum of care that we have here in Nebraska. Of the 683 patients that we admitted to our LTACs in the last year, 533 were Nebraskans from 63 different counties. And in my experience, those patients that need this level of care have no other post-acute care options. They cannot be admitted to an inpatient rehabilitation facility because they don't meet the criteria for intensive therapy because they're simply not ready for it yet. And they can't access a skilled nursing facility because of the need for the intensive medical management required by a team of doctors and nurses and respiratory therapists and other therapies and specialists. So this means if they can't access an LTAC, there's really no other choice but for them to stay in an acute care bed for perhaps a month or more. The Nebraska Hospital Association recently released a report stating that over the last month, there were over 227 patients in 1 month that were waiting for discharge to a more appropriate setting. Of those, almost half had been waiting a month or longer. So this creates a significant backlog in Nebraska's continuum of care and in acute care hospitals in particular. But we've been able to help our acute care partners by taking patients from them directly out of their ICUs or their step-down units, which allows them to free up beds and staff and other resources to care for new patients. And when we do accept those patients, not only are we managing their medical needs, but we're applying a rehabilitation approach. A multidisciplinary team meets with the physicians every day to talk about how we move patients towards better medical stability, greater independence, greater function, and how we return them to the community and their lives. And that's really our mission. And we're currently able to provide that valuable service for patients with Medicare, with commercial insurance, with workers' comp insurance, and with Medicaid from several surrounding states. However, we are not currently able to take Nebraska Medicaid because LTACs are not currently enrolled in the Nebraska Medicaid system. And we believe a lot of Nebraskans with Medicaid would greatly benefit from this service, and that's why we're supporting LB 434 and are requesting your support as well. Not only will it help patients in Nebraska who have experienced life-changing medical events, but it will also bolster the Nebraska healthcare system in a way that allows our acute care hospitals to continue to have beds and staff available for the patients that need their care. So thank you for your consideration today and your time, and I'd be happy to entertain any questions that you might have.
Thank you. Are there any questions from the committee? So just for clarification's sake, you said that there's 2 facilities that would qualify for this, or is there more?
Madonna operates 2 facilities, and as was mentioned earlier, Select Specialty operates 1 facility. I believe there are a total of 3 LTACs in the state of Nebraska.
Okay. And they currently take Medicaid patients?
From other states, but there is no mechanism currently for LTACs to accept Nebraska Medicaid.
Okay. Just try to get
So
my head straight.
we currently accept patients with Medicaid from Kansas, from Missouri, from South Dakota, for instance.
Okay. So then if this, I think I know what's going on with this bill, but so what's going to happen when this bill gets passed then?
I think some of those patients with Nebraska Medicaid that are currently stuck in acute care beds, they would move much more quickly into either Select's LTAC or one of our LTACs.
Okay, so it would, like, the fiscal truly is 0, right? I think once, because we're still paying for them now currently? Or no, we're not, right?
I'm not sure that I'm qualified to say that because I'm not an expert on how acute care is paid.
Yeah, for sure. Okay. I get my long-term, my acute care. The term long care, acute care facility throws me off.
Yes, it's
like
very
oxymoron.
confusing. It's acute care in that it's licensed the same as any other general acute care hospital in Nebraska, whether we're talking about, one of the CHI hospitals or UNMC or Bryan, but it's certified differently. But we have to meet all of the same Medicare conditions of participation as any other type of acute care hospital. The difference is that we have to maintain that long length of stay and have a very complex medical mix. So the long length of stay being at a minimum 25 days for an average.
Okay, because I know what my previous bill is trying to do is pay for Medicaid patients in acute care facilities. And so, okay, that's all. I just want to make sure I'm getting my analogies or my acronyms down. So, okay, any other questions from the committee? All right, seeing none. Thank you. Take next testifier in support.
Good afternoon, Mr. Chairman, members of the committee. I'm Jeremy Nordquist, Jeremy Nordquist, President of the Nebraska Hospital Association, and here today on behalf of our 92 member hospitals. I hope you don't mind, we're in the back talking, we should rebrand this the hospital happy hour on Friday here. Figure we're getting close to it. But here today in support of LB 434, and thanks Senator Jacobson for bringing this forward. It, as you heard, directs the department to enroll LTACs or long-term acute care hospitals as an eligible provider. And without that, those Medicaid patients can't receive that level of care. There would be no source of payment. And as Senator Jacobson mentioned, this was an issue that was actually brought to our attention at the association by Great Plains Health and North Platte. And since that time, hearing it from hospitals from Omaha all the way to Scotts Bluff with patients. And you heard yesterday from Margaret Weppel, our Vice President of Workforce Quality and Data, with our throughput report. And really that report came out of bringing together our, we call it transitions of care workforce, which includes transitions of care council, I should say, which includes hospitals, nursing homes, folks from the Department of Health and Human Services have participated, as well as the Office of Public Guardian. And again, a number of these bills have come out of it. But that report does show over the last 4 or 5 months that at any given time, and again, that's a monthly snapshot report. So at any given time, 230 patients waiting, 150 in rural hospitals trying to get into our larger hospitals, 90 plus sitting in emergency rooms waiting to get to an inpatient bed. That at any given time, there's 8 to 10 patients waiting for a long-term acute care hospital transition. So it's just another piece of the puzzle that we think is necessary to try to solve this. It isn't, going to address all 230 patients at any time waiting, but it certainly would address some. And to your question, we started talking to the department, some of our folks, and Madonna, it's probably been a month or so now, about the department sees this as a net even in terms of the care that some of those patients, while some of them are waiting, many of them are, as Mr. Lee said, could be transferred right out of the ICU. So if that patient went into our inpatient, we would get paid for a certain period of time. But if we can get them right over to long-term acute care, Medicaid would just pay for the long-term acute care services. So I think in Medicaid's determination, they didn't see a net addition of cost to it.
Thank you. Are there any questions from the committee? Senator Walz.
Thank you. Thank you so much for talking about the coalition of organizations. One of the questions I have is what when you're giving that report, do you also have information about the capacity available in other, like nursing homes, assisted living facilities? Is there a capacity report, what's available?
So that's an issue actually in the last probably 2 or 3 months that's come up, is who's responsible for mapping that capacity. And our hospitals will say, Dr. Ward mentioned a system that they use, but some of the hospitals literally pick up the phone and call 200 facilities, or will email 200 facilities. And we've been trying to say, how do we do this in a logical way? I mean, is it a protected, secure website or something where the nursing homes can come in and the hospitals can say, here's who we need to discharge, here's where they need to go. The issue with a lot of these patients, though, are the complicating factors. A nursing home might be able to say, yeah, we'll take a patient, but we can't take a mental health patient. We can't take a sex offender. We can't take somebody who doesn't have their payer and guardian lined up yet. So those are all barriers to just, there might be a bed, even a staffed bed for a patient with no complications, but most of these patients have significant complicating factors. So.
Any other questions from the committee?
Thank you for your time.
Thank you. Anybody else wishing to testify in support? All right, seeing none, is there anybody who wishes to testify in opposition? Is there anybody who wishes to testify in a neutral capacity? All right, seeing none, I'll welcome up Senator Jacobson to close. And I think we had, just to make sure. Yes, I did. Okay, that's fine. You can go ahead. Sorry, Senator Jacobson. I'll say it afterwards.
You don't see any letters on this one.
What?
You're looking for the letters on this one.
Yeah. Are there any?
What could impact my close, but I'm just gonna.
As long as it's not like 100 in opposition.
Yes.
All right.
All right, that's good.
I'm not seeing it anyway, so.
All right, that's good. Well, first, let me just say that I appreciate the committee's time today. I know it's been a long day, and I thought about waiving my closing, but I don't think it would be fitting if I did a close yesterday and didn't come back today and give credit where credit is due. That I do appreciate the fact that this was looked at from a bigger picture standpoint. The trade-offs and coming up with a fiscal note of 0 is appreciated. I think that we do have a problem out there. I appreciate the efforts of the department to try to do the right thing here. I think we all are in this together. We've got a significant healthcare challenge across the state. I can tell you, being from a rural part of the state, healthcare is critically important. If we're going to have economic development in our part of the state, try to reverse the tide of loss of population, we have to have a solid healthcare program. I appreciate the partnership that we've had and the hospitals have had with Madonna and other acute care long-term facilities. This is invaluable, and I think this will really help us in terms of being able to move patients that need to get in a place that can get better care and better long-term care and be better for the entire system. So thank you again for your time today. Appreciate it.
Thank you. Any questions from the committee? Seeing none. Thank you very much.
Thank you.
Now close the hearing for LB 434, and we will now open the hearing for LB 517 and welcome Senator Walz to open. Ready when you are.
Good afternoon, Chairman Hansen and fellow members of the Health and Human Services Committee. My name is Lynn Walz, LYNNEWALZ, and I represent District 15, which is made up of Dodge County and Valley. I'm here today to introduce LB 517, a bill to incentivize post-acute care facilities to accept difficult-to-place patients. The HHS committee has had a number of opportunities to hear about the challenges facing our hospitals, and in particular regarding transferring patients to post-acute care settings. The Nebraska Hospital Association reported that there were 35,500 avoidable days last year among the largest hospital systems. This means that hospital beds were filled with people who were medically ready to discharge and were not available to people who need that higher level of care. At the October LR 417 interim study hearing on this exact issue, there was a discussion about what happens when a patient is being cared for in their local community but needs a higher level of care. And according to the NHA, in January, there were 154 patients across the state in that specific situation. I did file and pass out Amendment 170, which replaces the bill. LB 517, as amended, would create a financial incentive for post-acute facilities who accept patients with complex needs as a piece of the puzzle in addressing the issue. I'm going to walk through this amendment and what it does. First, the incentive only kicks in when a hospital is at or near full capacity, which is defined at 80% of available intensive care unit beds and acute care inpatient medical surgical beds. Second, the one-time transfer incentives would be $6,000 for each patient placement in a nursing facility and $3,000 for each patient placement in a skilled nursing facility or swing bed hospital. Next, this incentive is only available for patients with complex needs. We are asking DHHS to work with representatives of acute care hospitals, skilled nursing facilities, and nursing care facilities to further define who falls under this category. In addition, we're making clear that any Medicaid or Medicare patient being transferred to a facility must comply with all reimbursement policies. Finally, we're making it clear that these incentives are not available for transfers that occur between facilities under the same ownership. Again, the intent of LB 517 is to be highly targeted and to focus on state funds on the specific intent of freeing up additional bed capacity. I believe it's in the state's best interest to make sure that there's capacity at our state's largest hospitals to ensure that they can accept transfers from other hospitals and providers in our state when necessary. An important distinction that should be made between hospitals and post-acute facilities is that hospitals don't get to pick and choose who comes through the door. That is why I think it's so important for us to create mechanisms that help solve this post-acute care traffic jam, which is currently resulting in less access to acute care patients across the state. Equally, or even more important, we need to find solutions that prevent someone from accessing care that is specific to their needs. This is a quality of life issue. Like I mentioned previously, I did pass out an amendment that would replace the bill, and I filed the amendment last week to give ample time for the public to review. Like so many bills this year, due to bill drafters' capacity, we were unable to get this version represented in an introduced copy. So the amendment better represents the intention of the proposal. There will be testifiers after me that can provide more detail from the hospital perspective. I'm more than happy to work further with them, the post-acute facilities and other stakeholders to create a meaningful solution to a serious problem in our healthcare system. With that, I'd be happy to try and answer any questions.
Thank you. Are there any questions from the committee? Yes, Senator Repeat.
Your choice, one or two.
I was gonna say something. I'm not going to.
Thank you, sir. My question, who was it that requested that you bring this piece of legislation?
I talked with the hospital association.
Hospital
Yeah.
Association, okay. I have two other questions. Are the payments, the $6,000, are those one-time payments or they're not?
One-time payment.
So however long the patient's there and they don't transfer out.
It is more of an incentive to bring
And
the
it's
patient
all
in.
up front. It's not spread out.
No, I think it's all up front.
Okay. And my other third and only other question would be is this only for Medicaid patients or is it for all patients?
I believe it's only for Medicaid patients, but I'll have to check on that.
Okay, thank you.
Okay, all right. I think you may have addressed this in your opening, but if not, I think the point of like your bill and mine and Senator Jacobson's and others, they're trying to address this problem is if the problem gets fixed and it actually works, then we don't need these anymore. You know what I mean? So we talk about fiscal notes and this other kind of stuff, but if we actually address the problem, these bills, we won't need them anymore, right? And so I think that's one kind of silver lining to look at, I think, with all of these bills, is that's the goal, is to actually address the problem here, hopefully, and fix it. So then we're not paying for all these, the problem in the first place. So that's kind of one of the goals here. So
Absolutely.
okay, all right. Well, you'll stay to close, I'm assuming.
For sure.
Okay, I'm not gonna run off. Okay, we'll take our first testifier in support, please.
Okay. So Dr. Vale and I did a coin toss, and it's my turn to go first this time. So, good afternoon, almost good evening, Chairman Hansen and members of the Health and Human Services Committee. I am Dr. Suzanne Nuss, SUZANNE, NUSS, Chief Nursing Officer for Nebraska Medicine. I described my facility at my previous testimony. Every day that a medically stable, ready to discharge patient remains in our hospital is called an avoidable day. Our health system absorbs the cost of avoidable days, as we are generally reimbursed a set amount based on diagnosis and complexity, not based on length of stay. Our health system experiences an estimated 27,000 avoidable days at a cost of about $24 million per year, and our number of avoidable days is rising. Of the 77 patients that are in our hospital ready to discharge, 40 of them are considered complex discharge patients. These patients with complex health needs often have multiple barriers that result in extended lengths of stay. The average length of stay at Nebraska Medicine for a complex discharge patient over the past 2 years has been 167 days. Many of our complex discharge patients have multiple health needs that require post-acute facilities to have specifically trained staff and special medical equipment. As our average daily census rises due to the increased length of stay, our stretched capacity limits the care that we can provide to patients who need us. As the state's tertiary quaternary academic medical center, there are some services that Nebraska Medicine is uniquely suited to provide, including treating certain types of emergencies, cancer care, and organ transplants. Our data shows the inverse relationship between our average daily census over the past 3 years and the average numbers of transfers that we are able to accept from facilities across the state. From an average of approximately 14 patient transfers per day, down to 8.9 in December of 2022. Annual avoidable days equates to approximately 3,900 patients whose care is delayed or denied because of the barriers to efficient post-acute transitions. We're also seeing a backup in our emergency department, with patients waiting significantly longer to be admitted to inpatient beds. Over the past 2 years, we have seen a 28% increase in the hours in which our patients are waiting in the emergency department, which carries a potential safety and privacy risk for patients. LB 517 is specifically targeted toward ensuring capacity at our hospitals that provide the highest levels of care. When a patient in a rural area has a stroke or a serious heart attack or other life-threatening health event, we need our larger hospitals like Nebraska Medicine to have beds available to provide specialized and comprehensive care. This bill and the amendment are highly targeted in a few ways. First, the additional financial resources to be provided to post-acute facilities as incentives to accept a patient transfer only apply to patients transferring from our larger hospitals. While all hospitals are struggling with post-acute transitions, LB 517 is targeted at ensuring capacity in our largest hospitals that offer the highest level of care. Secondly, the incentives for post-acute facilities in LB 517 only kick in when capacity at these larger hospitals is becoming strained at 80% capacity or greater, as reflected in the amendment. It's not available for all transfers from larger hospitals all the time. Finally, the additional financial resources for post-acute facilities under LB 517 are only available for patients with complex health needs, In this way, this bill is targeted toward the most difficult to place patients. I want to be clear that there's nothing in this legislation that would require any facility to accept a patient. The funding in this legislation is purely intended to offer additional resources for facilities that choose to accept patients with complex health needs. The amendment requires DHHS to work with stakeholders to set the details regarding the implementation of this process, to determine the process by which to determine and monitor capacity, to define the criteria for complex health needs, and any scenarios under which recoupment would be appropriate. This post-acute transition issue is multifaceted, as we've heard all day today, and there is not one policy that will solve it. The appeal of this proposal is that it provides a targeted financial incentive to post-acute facilities to care for patients that are the most difficult to place, specifically at a time when hospital capacity is being stretched thin. We thank Senator Walz for her introduction of this concept, and we look forward to working with this committee to help our health system address these challenges for our patients, for our hospitals, and for our post-acute facilities across the state. Thank you for your consideration. I'd be happy to answer questions. I actually do have an answer for Dr. Reeby. It's not just Medicaid patients, it's all patients, in case that's helpful.
It is all, you said all patients?
It's all patients, right? Right, it's all patients.
Okay.
So.
Any questions from the committee?
Sorry.
I do have a question, Chairman.
Our committee has a question.
Yes.
Yeah, it's a big question.
Yes, Senator Ballard.
Thank you. You talked about rural areas. Can you talk about the problem in rural Nebraska, especially dealing with long-term? I know Nebraska Medicine, Omaha, it's going to be a little different, but can you kind of shed a light on it?
Well, my understanding, having not worked there, but my understanding from hearing from my colleagues in the rural areas is that they are having the same workforce challenges that we are. So some have actually closed. But the bigger problem is that because we don't have capacity, they are having to hold on to patients, or they are having to make numerous phone calls to other systems to see who can take the patients that require a higher level of care. And so we feel bad for that because we like that pipeline and we like to be able to help to offload rural areas so that we can take the more complex patients. But when we're stuck, not to be crude, we've been calling it constipated. Our system is constipated. We can't get it. We can't get people out. So.
Okay.
Does that answer your question?
It does. So thank you.
You're welcome.
All right, good. Well, hopefully this collective amount of bills will be the Metamucil for your council. That's going to be great on the transcripts.
You know what? It's the end of the day on a Friday. We have to laugh.
A
Don't
long
we?
week.
Sorry. Yeah.
I do have a question. Have you looked at the fiscal note at all?
Briefly.
Because they do give like a report. I think it's the department gave a report of the amount of patients that they recorded over 90% and 95, 100%. And in the first month of 2022, you're looking at 30, the first month, 20, then 18, then 22. And then look at the last 4 months, which is October, November, December, and then January of this year, it's like 102, 49, 62, 53. Why the big jump all of a sudden? Do you know? Within the last 4 months, it went from like 30 to like 102.
I don't know for certain.
Yeah.
I'd rather investigate before you make an answer.
Yeah, that's fine. Because I figured it'd be higher. I don't know, maybe with COVID or something like that earlier, but now it's later. Just wondering. Okay. Well, seeing no other questions, thank you.
Thank you.
We'll take the next testifier in support.
Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. I'm still Dr. Lisa Vale, the Vice President of Patient Care Services and System Chief Nursing Officer at Bryan Health. I come to you today on behalf of the Nebraska Hospital Association in support of LB 517. At any given point in time, there are approximately 50 patients effectively stuck in one of the Bryan hospitals due to a myriad of complexities. They no longer have medical necessity for acute services, but require a level of care beyond what they could provide for themselves or what a home health aide might be able to assist them with. In 2022, our complex case care team reviewed cases of 975 patients that had identified barriers to discharging from the hospital. These barriers include guardianship, payer source, behavioral health needs, bariatric body habitus, and dialysis, to name a few. These barriers result in days, weeks, and even months in the hospital beyond what is medically necessary. For Bryan Medical Center, this resulted in 4,061 avoidable days. If the average length of stay for a patient is about 4 days, that's over 1,000 additional tertiary level care patients that could have been admitted to Bryan Medical Center alone. When a patient needs a higher level of care at one of Nebraska's tertiary care centers, and we have patients with excessive lengths of stay, it reduces access to needed services for those acutely ill. LB 517 will help hospitals create capacity by incentivizing post-acute facilities to take these complex patients at times of high volume, reducing that traffic jam that stretches across the state when a patient in Scotts Bluff, Albion, Valentine, you pick the town, needs a higher level of care that can be provided in their community hospital. Will the challenge of complex patient placement be solved by LB 517? No, it will not. It will take approaching this issue from a variety of angles to completely solve the crisis. LB 517 is one step toward building capacity in our hospitals for the patients that are most acutely ill. Over the last year, we have worked closely with our colleagues at the Nebraska Healthcare Association to find mutually beneficial solutions and remove barriers to establish a smoother operating system for patients as they navigate the continuum of care. We hope to continue this collaborative work. I'm grateful for the opportunity to share the challenges faced by patients not only at Bryan, but across the state of Nebraska. Barriers to post-acute placement impact every Nebraskan who needs medical care, from critical access to large urban medical centers. LB 517 is one of several solutions that will ease capacity for our hospitals and, most importantly, get every patient to the level of care that is most appropriate for them. As you have heard from myself and others today, I ask that you be moved to take action in support of LB 517. I thank you for your time, and I would welcome any questions you might have.
Thank you. Are there any questions from the committee? All right, seeing none.
Thank you very much for your time.
Take our next testifier in support. Okay, seeing no one else willing to testify, is there somebody willing to testify in opposition? In the neutral capacity?
I'm going to testify in opposition, but I will be happy to explain where that comes from.
We'll take the testifier in opposition.
Thank you.
Yes.
Please, it'll be okay. I promise. I'm always in the bad seat. So one day I'm going to come in support of something. Good evening, I think, at this point. Chairman Hansen, members of the committee. My name is Kevin Bagley, Kevinbagley. I'm the director for the Division of Medicaid and Long-Term Care at DHHS. I will note that while I am here as the Medicaid director, I'm also here on behalf of the department, as this won't just affect Medicaid patients. Here to testify in opposition to the current draft of LB 517, which would require DHHS to pay discharge incentives to post-acute placement facilities. I would first like to thank Senator Walz for the opportunity to meet with her and other stakeholders and discuss the bill, as well as some of the department's concerns. The reality is that there are patients in hospitals who need a safe place to discharge, as we've heard quite a bit today. And the department's committed to working with our hospitals, nursing facilities, and other stakeholders to find systemic and person-centered solutions to the problem. We feel it's unlikely that LB 517 will address the underlying issues that we've noted today. As I've met with hospitals, nursing homes, and other stakeholders around the state, and as we've talked about here, this is a multifaceted and complicated problem. Generally, nursing facilities have every incentive to admit new patients, and a decision to deny an admission typically takes one of the following forms. The nursing facility doesn't have adequate staffing to take new patients, regardless of complexity. The nursing facility is not equipped to meet the unique needs of the patient. These patients may require specific equipment, such as bariatric or other specialty beds, that can cost tens of thousands of dollars to procure. Or somewhat relatedly, the nursing facility believes they cannot safely serve the patient who, in many cases, presents with behavioral health, behaviorally complex issues sometimes even including a history of violence. While this isn't an exhaustive list, these are three of the primary concerns that I've seen in discussions that I've had with hospitals and nursing homes. When nursing facilities take on these difficult clients, they expose themselves to significant risk. Federal regulations make it incredibly difficult to discharge clients once they're admitted. Additionally, in cases where a resident assaults a staff member or another resident, the facility would potentially become subject to certification findings, civil money penalties, and other issues. Given these complicating factors, it seems unlikely that this incentive would substantially impact the underlying issue. Written, LB 517 will require hospitals to notify DHHS if capacity reaches or exceeds 90%, though the proposed amendment would adjust that threshold to 80%. Upon discharge of a complex patient for a hospital that exceeds that capacity threshold, the bill requires the department to pay a discharge incentive to a post-acute facility accepting the patient. Our existing data suggests that hospitals regularly exceed these thresholds in any given month. DHHS's data systems and payment processes do not currently meet the requirements in order to be compliant with LB 517. Should the bill proceed, our payment system would have to be replaced with a more automated system in order to make the required discharge payments. And we would need to procure a system that would allow us to do more management of real-time notification from hospitals of admit, discharge, and transfer data. The reality is that every case in which hospitals struggle to safely discharge a patient has its own complexities. While the proposed amendment does give the department the latitude for defining a patient with complex health needs, it'll be difficult to appropriately define the criteria. Finally, and this is really, I think, the primary concern we have and why we're here in opposition, the bill does not establish a ceiling for the total payments that would be made in a year. While we've tried to work out an estimate and make that as accurate as possible, the likely outcome for these payments, if the number of incentive payments exceed appropriated amounts, the department would be obligated to continue making those payments, whether or not we had that allocated in our budget. So thank you for the opportunity to testify today. I'm happy to answer any questions.
Okay, are there any questions from the committee? Okay. So you mentioned the need for a ceiling, and you're talking about like, are you talking about a dollar amount or more like the amount of patients?
Well, I would say
they're both kind of the same. You know?
They're both largely the same. The reality for us is, absent a ceiling on the amount of money available through these for these payments, it would put the department in a position where whether or not we had the appropriation, we would have an obligation to make the payments.
That makes sense. Do you see the potential, and I'm not saying it's going to happen, but could there be a potential for abuse with any of this?
I think it would put the department in the position to ensure that we needed to have some accountability on these. We would have to write some rules around that. There's always the potential for that, but I think that would be incumbent on us to ensure there was appropriate accountability in place.
Okay, and can you speak to the fiscal note? I just had you're looking to hire 2 employees.
Yeah, and that largely has to do with the kind of administration of these payments. It would function a little bit like a grant, okay. Although not quite in the same way. And so those 2 staff we feel relatively confident about the need for additional staffing to administer these payments. They're not specific to Medicaid. The real is how many of the payments would be made. And while I mentioned in my comments, I'm not sure that this will address the underlying issue. I would love for the underlying issue to be addressed. And if this does it, we could potentially have a lot of payments that we'd be making. And I think that's where the largest concern for us lies.
Yeah, I think this seems like I don't know, it is a multifaceted problem. This seems like a cog in a wheel, right? Like one of the things that can kind of help fix it, because I think where you're hoping the money then they'll go to the long-term care facility to maybe hire new staff. I mean, or to, well, do those other things that we're missing or fix some other infrastructure to take some of those bigger patients. So it's at least what we're hoping for anyway, so.
Certainly. And so I want to make sure I'm clear with the committee and Senator Walz with you as well. It's not that we have an opposition to trying to solve the problem.
Yeah. Cool. Just making sure no questions. Okay. All right. Thank you very much. Anybody else wishing to testify in opposition to LB 517? Okay. Is there anybody wishing to testify in a neutral capacity? All right. Seeing none, Senator Walz, welcome you to close.
All right.
And with that, we did have one letter for the record in support of LB 517 from the Nebraska Association of Home Health Care and Hospice.
All right. First of all, Senator Reedy, I was 0 for 2 on your questions. It does include not only Medicaid, but all patients. Correct.
Thank you.
And it was not the Hospital Association, it was Nebraska Med.
Oh, okay.
Okay.
Okay, thank
So,
you for.
sorry about that.
No.
Well, thank you to all who came to testify on LB 517 and really to everybody who came to testify on all the bills that we heard today. It's really important to keep in mind that this bill obviously is not the silver bullet. As we talked, it is a very multifaceted issue, and Director Bagley and I, as well as others, had a really good conversation about that yesterday or 2 days ago. I don't remember what day it was. But we have, as a committee, have heard several bills, and we will be hearing more bills that address the quality of life and access to care for Nebraskans. I think that when we're discussing these issues, we need to be thinking of the whole picture. We should be thinking of creative solutions brought to us by the experts that are looking to address these very real issues. And I think it's really important to remember that we have the opportunity to do something really special this session and create a thoughtful package of legislation that creates access to the problems we have with our healthcare and providing quality healthcare to Nebraskans. So with that, I try to answer any other questions that you might have.
Okay. Are there any questions from the committee? All right. Seeing none. Thank you very much.
Thank you, Senator.
And that will close the hearing for LB 517. And that will close the hearing for today. Christine, whenever you get that.
Are we going?